Okay, pause. Okay, obrigado. Okay, so welcome and good morning, everybody. It's great to have you here with us, and please join us in the auditorium, and also our Zoom participants that are already in the waiting period of our summit that's going to start in a few minutes. It's really exciting times we are living as we kick off the day one, and already waiting for all participants to join the table, which will be in a minute. And I will be introducing them to you also in a few minutes too. So please find a good seat and pack your stuff if you want to take notes. Okay. Almost the final countdown for us to start. 4 minutes to start. Yes, that's great. And we are holding here 2 spaces for our latecomer speakers. This is a very intense traffic today, and as we say in the broadcast industry, the show must go on. So we'll be starting in order to make sure that we've finished this day on time. And for the ones who are lucky to be invited to go to the official dinner in honor of our guest speakers, we'll meet later today at 8 p.m. So it's going to be a long day. Welcome all Zoom participants. It's great to have you here. We have 300 registered participants for online participation that will probably going to join us throughout these 2 days. It's the biggest Health Data Forum Global Hybrid Summit ever, and this is a reason for this. I will explain in a minute. So please grab a seat as we start in 3 minutes, and hopefully getting live. We are already live now. So welcome everybody who are watching us in the social media. It's really great to have you all here with us today and following our event live on social media. We are being broadcasted live in several channels, mainly in YouTube, LinkedIn, also Twitter. So if you follow Health Data Forum social media, you will be able to also to watch us on social media, but of course you're more than welcome to stay in the Zoom room here, as we welcome your comments on the room and on the chat. I will be trying to get as much of your feedback from the chat as possible. So welcome everybody, and please grab a seat and unpack your stuff. Make yourself comfortable. This is going to be a long day.
But a nice long day.
Yes, a nice long day, Geert and Jens. Good morning, Jens and Geert. Good to have you here. I'm not sure if the camera can pick you for... Oh, and we have here already Dr. Rui Santos Ivo, President of INFARMED. Good morning, Dr. Rui Ivo. It's so sorry that you cannot join us as last minute.
Good morning. Good morning. I really apologize.
But that's the purpose of having a global hybrid summit, is that we can accommodate participants from wherever they are in the world. And
that's true. That's true.
And it's very good to be able to have this interaction thanks to this new era we are all embracing. Hybrid workplaces, hybrid events, hybrid meetings. What's really important is that we extract the most possible value from this. And I think it's 1 minute to 9 o'clock, right? So we are going to start as I think Professor Altamiro is joining us in any minute, and then obviously we'll be addressing here the audience, as well as Ricardo Jardim Gonçalves. If you will be here at 9 o'clock, kindly invited to join us here in the table. And it's good to have a good attendance on Zoom. Also, we have 300 registered participants for online participation and 150 participants locally. So it's the biggest Global Hybrid Summit ever. And it's good to see you here, Dr. Ruivo, because I remember the first edition during pandemics where we were in INFARMED. I was completely alone with you and the audience was zero. Online, of course, it was packed, but in presence, the auditorium was empty, and it was a very historic day, right?
Yeah, it's strange, but yes, it is marked on our memories. Yes,
we managed to beat the pandemics, and INFARMED played a pivotal role in our country, in Portugal, of course, but also in European coordination that we have managed to overcome this pandemic, and it is really something that we as humans should be proud, right? Because we overcome the virus in a fantastic way. Science moved in fantastic way, and we are all here today now, not wearing masks. Can you imagine this? Okay, so as we approach 9 o'clock, welcome everybody. It's good to be here with you. My name is Paolo Nunesdea, and I am the fire starter of the Health Data Forum. The Health Data Forum is an NGO, a non-governmental organization. It's a civic platform. We are not for profit, and we create collaborations like the one we have today that is hosting this event. Namely, this faculty where I am right now, Faculty of Medicine of the University of Porto, and the Dean will be joining us in the table any minute now, as he's just being delayed by the traffic, and also the European Institute for Innovation through Health Data. And we have here with us in the table already, Geert Thienpont is the director of the IHD, and Jens Declerck, director of Health Data Quality in the IHD. So they are, along with the Faculty of Medicine of the University of Porto, the co-hosts of this event. And this is the reason, this collaboration that we started is the reason why we have the biggest so far Global Hybrid Summit with the massive amount of participation, not just in quantity, but also in quality. Geert, Jens, good morning.
Good morning,
would
Paul.
like to fill in some space as we are waiting for Professor Altamiro and Ricardo to join us.
Thank you for the introduction, and also thank you for welcoming us. It's for IHD a big honor to welcome you all as first. So good morning, ladies and gentlemen, friends, colleagues. Welcome to you all here in the room, but not only in the room, but also the participants at their office, at work, or at home, or even cozy in the sofa, if you're living on the other side of the world. So a warm welcome to you all. And it's always a pleasure. As you know, it's not the first time we are organizing a conference. Since IHD was born, we organize every year our conference, and it's nice to see that friends are coming back to listen to us, not to me, but to the speakers. And yeah, it's always nice that they are learning from us, but more important is that we are learning from them. So thank you for that. I also need to start with a bad announcement. Normally it was our President Deepak Kara who would welcome you here. But as we speak, he is undergoing surgery. Not that worse, he told me, but yeah, it's a surgery. He also told me that he would come, not here, but he will try to participate tomorrow remotely. We will see if he's healthy enough to join us. But the IHD team is growing. and we have backups to replace Deepak, and even by someone who recently joined our team, Mats Sundgren. I think since a few weeks he joined us, but he knows IHD very well because he was one of the co-founders 7 years ago. So he knows us very well, and we know Mats also very well. So thank you much for helping us here today. I know that thanking people is normally done at the end of the conference, but I would like to start with that because it was a huge activity to get this organized, and I would like to thank the organizing committee and the program committee, but more specific Professor Altamiro, Professor João, Pedro, Professor Ricardo, and also Paul. Thank you very much for hosting this event and for co-organizing, and also thank to my team IHD for making it to a success. Thank you. About IHD, our institute, the European Institute for Innovation Through Health Data. Please allow me to read the vision of our institute. We strive for a world in which multiple stakeholders collaborate in the trustworthy use of high-quality health data to improve care and accelerate research. And we know all very well that we need data to improve our care and to accelerate research. But there are some obstacles that we need to tackle so that we can make better use of our health data. We have a booth. You are welcome to learn more about us, about our services. I'm also happy to announce that we have a new quality seal. It's called EDIS, and happy to tell you more about that at the booth, but it will also be announced during one of the sessions. Before giving the floor to my colleague Jens, who is our data quality manager, he did a lot of work to make this very, very nice program. So thank you, Jens. But before giving you the floor, I would like to give the floor to Professor Altamiro.
Yes. I think you can proceed with Jens, and then in the end,
Okay.
Professor Altamiro will give me the last remarks. Yeah.
Thank you. Good morning, everybody. Just to start with a small adjustment, I'm not a data quality director, that Paul mentioned. I'm just somebody who works on data quality at IHD and also doing shortly a PhD on data quality, which
But it's more fancy to be director.
Maybe, yeah, it would be nice to be director, but I'm not to be just to be honest. So as everybody know by now, this two-day conference will be about data quality, health data quality. And in my opinion, one of the most important challenges within our healthcare ecosystem. At IHD, we like to refer to data quality as a dynamic complexity. You see it on the titles of our program, also in banners or in marketing promotion campaigns. So we try to call it a dynamic complexity. And in my opinion, these two words really capture the essence and the importance of data quality itself. It's also two words we try to use during the development and the creation of this program. Data quality is an ever-changing requirement that needs to be redefined over time and over different projects. And achieving, maintaining, improving high-quality data is very difficult. It's not easy. And it really depends on different aspects, different complex aspects. For example, this afternoon, or this, I think, in an hour and a half, we will start with some sessions on ICT systems, software systems, on interoperability, GDPR, information governance. So all these complex aspects, they affect data quality. So that's why we call it a complex environment. It's also dynamic. It's also changing a lot and very fast in this ecosystem. For example, and then we have sessions in the afternoon on the European health data space with new requirements and so on, but also with new developments related to data quality, related to health data, which impact the quality of the data itself. Also, AI will be a very important session this afternoon. It will be very interesting as well. Also achieving, and this will be more addressed during day 2, achieving high quality data is not a one-man job. We really need all stakeholders within the ecosystem to thrive and to maintain, achieve high quality data. And every stakeholder within the ecosystem should actively participate in the quality effort. But the very important question we will ask ourselves tomorrow is to try to get all the stakeholders in this effort. What's in it for me? What's my gain? What's my return of investments? From a patient point of view, patient safety, better outcomes. From another point of view, the pharma, for example, how can we foster innovation? But also maybe from a financial point of view. So these things, we will address them tomorrow during a whole day where we have different stakeholders and where we have very nice discussions to try to formulate some calls to action and to try to get an answer on this very difficult question. And to really foster the discussion, that was the reason why we tried to get all the people, participants, speakers to Porto to really have these very active, vigilant discussions. Thank you.
Thank you. Thank you so much, Jens, for this outlook of the program. And now we have the table here complete, and it's my pleasure to give the floor now to Ricardo Jardim Gonçalves as the full professor at and the director of Uninova, our premium sponsors this year. Ricardo, it's so good that you have made this collaboration for this year. And I think maybe you can use the microphone from Professor Altamiro and share your contribution there to give the floor for a welcome remarks.
Okay, so good morning, dear Professor Altamiro da Costa Pereira, Dean of the Faculty of Medicine, University of Porto, the organizers of this forum, dear colleagues, ladies and gentlemen. It's really a privilege and an honor to be here seated this time here in Portugal in the starting of this very important forum on health data. This is really a very important moment where we are facing the digital transformation all over the world and coming back from our last years with the pandemic, we more and more realize that the digital is absolutely crucial for our society. There has been a lot of research, a lot of innovation, a lot of developments during the last decades concerning data, concerning digital data, and more we are finding that is crucial to transfer all these major results to the citizens, to all of us, in order to take advantage of these capabilities and of these technologies. Portugal indeed is playing a crucial role in the digital data transformation and including in digital health. Portugal is leader and coordinating the major European Commission e-health project addressing exactly or using exactly data where the quality of data is also very relevant, because without that quality, the data that we have is useless. And Uninova, that is the Institute for the Development of New Technologies that belongs to the campus of the Faculty of Science and Technology of the Nova University of Lisbon, is indeed one of the major European players in this area, and also in Portugal is top leader in this domain. I'm very glad to be here and also to inform that all the work that have been done is presented in this forum. You have a booth outside where you can experiment, you can see, you can discuss with my colleagues that are here present what have been the major achievements that we are doing during these last years in this area. And also we have a keynote address this afternoon. We are also moderating a session, and tomorrow we have another keynote address where you can understand in depth what have been the major contributions that we are doing for the society during this development of the projects. Nevertheless, and before I finish, I have to say that indeed to use more and more and take advantage of more and more of data with quality. The literacy in digital is fundamental. It's fundamental not just for those that are now starting the studies, but also for those that are already in the working market and need to have some further insights to really take better advantage from the digital and from the data with more quality. And exactly about that, the European Commission launched through the Digital Europe program a call for digital skills in different domains. And we applied for digital skills in digital health. It's an international master in digital health that was funded, it was approved, it's a 20 million euros initiative or project that Uninova and myself, I am the pedagogical and the scientific coordinator of this international master. And I'm sure that we aim to use this international master as a mechanism to bring all Europe to a next level of literacy in digital health, including, of course, data. This will be a big opportunity for all of us to work together, collaborate, and provide further to our society. Thank you very much.
Thank you so much, Ricardo. I ask a round of applause for showing our remote participants that we have a live audience here, and as incredible it seems, we have here an auditorium and it's full of participants that are attending us. Not yet totally full because this is still in the morning, but it's already half full, and I'm glad that you are all here in presence with us. It's really a pleasure. Last intervention on this welcome session will be for Professor Altamiro da Costa Pereira, the Dean of the Faculty of Medicine of Porto University.
Good morning. Well, I just want to leave here at this wonderful audience a word of welcome. Welcome to Porto, this beautiful city of Porto, and welcome to the Faculty of Medicine of the University of Porto. It's really a pleasure to be here at this opening session with you all. I am very happy personally and institutionally, and I am very proud of what we have and we all have achieved in the past, let's say, 20 years or more since we first developed the first steps at this area. In fact, data quality and health data, it is a very challenging environment. It's full of problems, technological, sociological, political, etc. But the rewards are also great. Within this, I am also very grateful, of course. We could not be here if it was not our sponsors, if it was not all those who have believed in this conference. Uninova was also one of our sponsors, and I'm grateful to it. And of course, it is very good to hear all the exciting news Ricardo have given us regarding the prospects in Lisbon and in university. But here in Porto, we have started, as I said, more than 20 years ago, we have launched a master program in medical informatics that have now been credited by FME. We have tried hard to work on all these matters with the main stakeholders, the hospitals, the health centers, all this. And we cannot really go for true progress if we don't put together computer scientists, all the technology available, but also health professionals and all the problems that they face. That's only by bringing these two words together. When I started within this area, I came across with two eminent professors at the time, but mainly coming from the technological field. And they told me, oh, you want solutions. You have problems, we have solutions. Well, I must say that this did not work at all. People from technologies, they may be part of the solution. I'm fully aware and fully in agreement, but they are not the solution. The solution, it is much more than a technological solution. It is, it has to do with literacy, as you said. It has to do with many other issues, like ethical issues, economical issues, societal issues, etc. And only if we bring together all these different stakeholders, we can really have progress and trust and quality in the data, because data, if it does not have quality, it is this old saying, garbage in, garbage out. We need to improve in all these matters, but I'm very confident, and we are very committed here at Faculty of Medicine and in Porto, and I'm very confident that with the help of not only Uninova and our sponsors, but especially with the community at large, Europe at large, we must really do our jobs, which is really to make useful things from all the wonderful data we are collecting, and put these useful things towards to improve health outcomes, health efficiency, and ultimately to benefit our societies. Thank you.
Thank you so much, Professor Altamiro. And this is wonderful news that we are 10 minutes in advance of the program. So let's take advantage of this time to switch the tables now for the next coming panel that I am also going to introduce, and shared by Vanessa Candeias. I would invite the guest speakers, please, taking the front row here, and a round of applause for our opening panel and finishing 10 minutes ahead of time. Huh? And for the participants on Zoom, we are going to do a little bit of a waiting area now, so you can perhaps grab a cup of coffee or something as the changes are moving. And we see already our online speaker, Dr. Thienpont, is already in Zoom. And I was told that he will be the first to intervene due to commitments in agenda. So we are going to do this light exchange of the program. And Vanessa Candeias, will introduce her while we're waiting for the change to sit, is a global health specialist, and she's also the Health Data Forum Global Ambassadress. So she has given us the honor to represent and to spread the word about this non-for-profit and ONG organization, which is the Health Data Forum all over the world. And Vanessa has a wealth of experience as a specialist, worked in the WHF, in the World Economic Forum, as a healthcare responsible for the events in the WHF, and also in Geneva, where I met her. But she's from Porto, so that is the reason why we are lucky to have her here today to share and moderate this table. Vanessa, you are here already? Okay.
Yes, thank you.
Fantastic. Maybe. And Professor Ricardo and Professor, maybe you can take a coffee. Yes, the two of you. It's good. You speak together. There's a good importance that the outcome from here. You can take a cup of coffee. There are tickets for coffee upstairs. You take them in the reception area. Also for everybody. We'll line up this information. So I'm just introducing Vanessa Candeias. She's the sharing this and moderating this panel now. And Vanessa will be the one who doing the introductions of the speakers. And over to you, Vanessa.
Great.
Maybe we can start with some time ahead, more time for discussions,
Yes.
for debates.
Yes, having more time is always good. You know, I'm Portuguese, but I've been living in Switzerland for over 20 years. And so I have a very strong internal Swiss clock. So anytime we can start on time, start before, it's a good thing for me.
The
So
floor is already yours.
thank you. Good morning, everyone. Thank you, Paul. Thank you all for being here and for joining us online. It is my pleasure to be here, my own hometown, and to open the keynote speakers together with our panel this morning. As Paul was saying, my name is Vanessa Candeias. I am currently a senior analyst with an organization that has its headquarters in Australia called Policy Cures Research. And I lead our work on assessing the impact and the return on investment of the past 20 years of investment in R&D for emerging infectious diseases and neglected diseases. But I've been working in public health for 20 years, so it's really my pleasure to be here. Let me start by welcoming our keynote speakers. So we have online Rui Santos, the president of the Portuguese National Authority for Medicines and Health Products, the INFARMED, and I hope you can see it. I can't see it here. Let me see if it pops up. Great. Hi, it's very nice to see you there. Sofia Nogueira da Silva, the president of the Portuguese Regulatory Health Authority. It's very nice to have you here next to me. And Paolo Alcini, head of healthcare data at the European Medicines Agency. Hi, Paolo, and it's a pleasure to welcome you to Porto. Sorry about the rain yesterday. I think we're going to do better today. As the first session and in trying to set the scene for the coming 2 days, I hope what we will hear this morning will help frame some of the key questions that will be discussed, that we will be collectively discussing in our various sessions coming up. From my side, I always approach digital health and healthcare data asking data quality for what? What do we really want to use this for? We don't want data quality just for the sake of having more data and it being very high quality, right? We want it for several purposes to make our lives collectively better. So from my perspective, we want it for one, decision-making, and this can be by policymakers, by regulators, by businesses. It could be pharma, it could be healthcare providers, it could be insurers, you name it. It could be caregivers. And of course, we want it for decision-making by the patients. We want better data quality for better patient outcomes and for improved management of population health. And we've seen that with the pandemic, how critical it is to have the perspective at the individual level and at the population level, both at the community, the national, the regional, and the global levels, so that we have all of these connected with good quality data. Of course, we want it for innovation and solution finding, but as Professor Altamiro was saying, the technology is not the solution itself, right? It's going to help us to get to where we want to go. And then fourth, from my perspective, we wanted to drive sustainability of the healthcare systems. We want data-driven and sustainable healthcare systems. And without it, it's hard to justify bankrupt healthcare systems without data or very high quality data that is not fueling a good quality healthcare system that is accessible to people when they need it at the point and with an affordability that they can benefit from. And so as we go through the next days, I'm hoping we keep in mind, what is this health care data quality for, and how can we get to it and use it to our collective benefit. And so without further ado, and as I said, my internal Swiss watch doesn't let me go above time. Let's get the panel started. We know that you have a hard stop at 10. So maybe we start from your side there. As I was saying, high quality data is critical for decision-making across the entire healthcare ecosystem. And so what we're hoping you can set the conversation for us here with what are some of the key regulatory features framing the use of health data for access to medicines? What are some of the key challenges and opportunities for policymakers in using health data for the benefit of individuals and populations? And what are some of the areas where you have seen healthcare data being used most efficiently and with the most benefits for us all as patients and as users of the healthcare system? Over to you there, and I know we have your slides ready to go. So if we can pull up Zivu's presentation.
Thank you very much, Vanessa Candeias. Thank you very much. It's a pleasure to be here. I really am apologize and I would like to be in Porto, but unfortunately the agendas are still very heavy, particularly in November, so I do not have the possibility to be there with you. Let me also thank again Paolo for inviting me for this event, so this important health data forum. A greeting to the colleagues of the panel, Professor Sofia, Nogueira, Silva, and also Paolo Alcini. It's a pleasure to be with you even on this way. I've been in many occasions with Professor Sofia Nogueira da Silva and with many colleagues from the MA. I would have certainly the opportunity to meet Paolo Alcini in a future occasion in person, and I look forward to it. So as Vanessa was saying, I will try to address the points that were raised. I think and also I heard the introductions, and allow me also to say a word of greetings to Professor Altamiro da Costa Pereira. We have a long-standing collaboration between INFARMED and the Medical School of the University of Porto. And of course, this is a very important topic, the quality of health data. We have also seen from the past years during this pandemic the importance of the use of the data, particularly when we talk about the generation of evidence, and also, of course, the importance to look into the various issues that are connected and to work as much as possible together. Of course, as Vanessa has rightly pointed out, we also need to answer the questions: why do we need the quality of the data? So let's start with the slides, where I want to where I want to make a few points. I'm not sure if I'm supposed to move them or if they are moved from your side. So just the first one after this one. So here I just wanted to highlight a very important feature we have in the Portuguese system, and I think it was Ricardo Jardim Gonçalves who mentioned it. In fact, I think it's very important to say that Portugal has a very strong developments in the area of health data, and we are not only leading this issue at European level, but in fact, if we look back at what we've done in our health system is very remarkable in terms of these developments. And here I wanted to highlight this issue of the electronic prescribing, which we have completely covering the outpatient sector. and this is of course very important because it links easily to the electronic health record, and also in the hospital sector. Of course, there are still some differences across the system, but certainly now also with the recent developments in terms of governance, this will also evolve. And this is a very important feature in terms of gathering important information from the health system. Then I wanted also to look into the INFARMED's, the previous one, please. Just to briefly mention our areas. We are what I call an integrated regulatory agency, so we don't only cover the typical regulatory areas, so clinical trials and marketing authorization, but we also go beyond that, performing health technology assessment and then also being involved in pricing and reimbursement. But of course, we also do all the activities in terms of surveillance of the use of the different technologies. So in terms of pharmacovigilance and quality control, and also in a more broader way on monitoring the utilization of the products we regulate. So mainly medicines and medical devices in the health system. This is also an element that is becoming more and more important. That is the integration of the different areas and the possibility to identify the links of the needs in terms of data between the different areas, because more and more they are interrelated, and I will allude to that later on. So on the next one, just to start, just to make some references on the importance of health data. Of course, the improvement of the use of medicines and health outcomes, this is very relevant. Another important issue, and Vanessa alluded to that, is to improve efficiency on the use of public resources. This is key in any system. Of course, in a more specific point, to support and make possible the assessment of our decision making, and of course also to support the development of medicines policy. And I think there is also an important element that health data can help us in being more capable of predicting development. So looking to the different trends, so to reinforce our capacity in this respect. The next one, and here I will not repeat because I think I mentioned a little bit, but it's just to highlight that our monitoring system we have is already integrating the different sectors in the NHS. Here, of course, we collaborate also a lot with our colleagues from different departments that will come also in the sessions, the SPMS and also ACSS, so the Health System Administration, and the department that is in charge of all the information systems. So we collect the data from both the hospitals, from the outpatient sector, and from other sources like disease registries, pharmacovigilance systems, etc. And we integrate as much as possible this information in terms of our activities. And this information, it's then reflected on different activities that we perform daily. You can see many of them in this slide. So as I said, from the very beginning, by performing horizon scanning, so identify earlier the trends, also to the marketing authorization, to the HCA assessment, to the reimbursement, and then of course to the monitoring, and to also then perform reassessment of our own decisions. Vanessa, you tell me if I'm going out of my time.
Don't have time.
Just to highlight two use cases that we on the work we do. So one is related to the hospital use of medicine, so the consumption and the feedback that we provide to the different organizations of our system. So to all the hospitals, but also to, of course, all the departments that are involved in decision making, and including our ministry. So here you see a number of areas where we provide this kind of information on specific antibiotics, being a very important area where we have to be very efficient, very careful in its utilization. Tomorrow it will be the antibiotics day, where we'll have also meetings to discuss very important issues in the particularly in the area of antimicrobial resistance. On HIV, on the use of biosimilars as a very important element to the sustainability of our systems, and then on particular areas of medicines like multiple sclerosis and others. Another element is a very important. So the next slide, please. Is a very important system that we have in place in Portugal, which is the national, the national disease registries, but here particularly the National Cancer Registry, which is a national system that was developed and was integrated a few years ago in 2017, if I'm not mistaken with the date, in 2018, it's in the slide, when it was integrated across the country, and where we can not only have all the data related to cancer diagnostics and treatments, but particularly also to focus on the use of medicines, and this in collaboration with us. You can see some of the examples that we are already covering by this system, particularly areas of very high development, like the use of CAR-T cells, by their complexity in terms of utilization, but also in terms of the cost and in terms of the importance of monitoring the results. So this is a very powerful tool that we have by having an integrated system in Portugal. I wanted to go to the last part of my presentation, just to make a short note on what is going at European level. I'm spoken mainly now about things at national level. I know that Paolo Alcini will take care of that aspect, but just to also to reinforce an aspect that is how important it is to have this collaboration. And as you can see in this slide, at European level, we are looking at these aspects, of course. Also from our side, from the side of the regulators, we have a joint strategy. Here, it's not mentioned here specifically, but we have a joint strategy which brings together the European Medicines Agency, and Paolo certainly will talk about that, and all the national agencies together to develop a common strategy in many aspects. One of them is exactly the use of health data analytics, the quality of data. And so there is a big data steering group that has been established. There is a very specific project, which is the Darwin EU, and which aims to create a central system for data. And of course, you know the developments that are ongoing in terms of European legislation, so particularly the European health data space, but also the medical devices regulations will have an important impact here, and also the health technology assessment regulation, which will be implemented, and this will also bring more collaboration together. And I think I have now to finalize. So just to the next one, just so some of the challenges I wanted to highlight. Of course, it's very important in our context to identify as early as possible the development of new technologies, and consequently the evidence that is required for assessing them. Of course, the quality assurance is paramount, and the development of methodologies and strategies that aim at that is essential. And of course, we need to have also qualified people that will be able to deal with this type of information. Then to just leave you with a couple of takeaway message, I wanted to mention three points. So one is health data can provide and promote benefits for healthcare and public health. Here, of course, I should also highlight the issue of affordability and sustainability. So this is very important in terms of treatment outcomes and the use of medicines. It's also important to create the conditions to support the role of the regulatory agencies. I'm sure that my colleague, Professor Sofia Nogueira da Silva, will also refer to that. So it's essential that we create the conditions to use this in our work. And finally, I wanted to highlight also a point that has been mentioned before, which is collaboration. We need to have a strong regulatory system, but also to ensure that there is a strong collaboration. In some cases, like in INFARMED, we have many areas that are already within our agency, but when it's not the case, we need to create the mechanisms to collaborate between each other. And these are my final messages. I thank you again for being here, and I apologize for not being able to stay during all the sessions. Thank you very much.
Great. Thank you, Rui. And I think you've made very important points to help us to guide the discussions that we will have. I really appreciate the point you're making around feedback loops, because be it for antibiotics or for multiple sclerosis, because without those data-driven feedback loops, we cannot course correct and we cannot adjust to the needs of the patient. So I think it's really important to highlight that. And also it comes across very clearly the very strong collaboration that is fostered not only between across the various national and government agencies, but also at the European level and between public and private sector. You are saying that for patients, they can seamlessly go having their prescription from a private healthcare provider, from a public provider. And I think that is one of the benefits that really helps make the how patients go through the pathways of care in a more positive way. So I really think that comes across very nicely. And I do think that keeping in mind that governments alone and national agencies alone are not going to be able to respond to all the challenges of health data quality or all the other challenges of the healthcare ecosystem. And so being able to foster this collaboration and keeping it open, I think it's really important. Taking advantage of the last few minutes where we still have you with us, maybe I will see if there's any questions either from the audience here or from online. I can see a hand raised up there. Do we need a microphone there? Or can he just speak? Okay. I can hear you and I can...
I try to see if Miguel, you can bring a microphone, Miguel. Sergio, please.
Otherwise, floor. I can repeat the question.
We have a microphone there.
Okay, great. There you go.
Hello.
Thank you. Thank you, Reggie.
Thank you for the good presentation. I'm Markus Kallio from the Finnish Innovation Fund. And I would like to ask Rui about the digital medical devices or digital therapeutics. Germany has launched a new legislation in 2019 that digital therapeutics will be approved in a national system. And there's a national reimbursement scheme for these digital therapeutics so that the doctors can prescribe patients these applications for treatment purposes. I think it's the first of its kind in Europe. And I had a question whether Portugal will follow suit and have something similar in the future.
Great, thank you. There was another hand up here up front. Do you still, yes, if we can bring the microphone down, please, and we take perhaps these two questions before handing it back to you, Chloe. Yep.
My question is regarding Darwin and how do you see connected to the European health data space policies? Thank you.
Great.
Thank you.
Great. Thank you. Rui, perhaps over to you for a few reflections there.
Yes, thank you. Thank you, Vanessa. Thank you, the colleagues, for making the questions. In relation to the medical devices, certainly we are very focused on developing the area. We had some let's say, less sophisticated areas where we have intervened, it's a coincidence that, in fact, this happened during the time that the current CEO of the NHS executive, Professor Fernando Araújo, was a member of the government, where we framed mechanisms to have access to certain medical devices through the prescription system. And this is something that we are discussing in terms of how best to have the utilization of the different medical devices in the system. You know, it's very complex now to link all the dots, because we have the new legislation which is putting some challenges to us in terms of its implementation. We have the complexity that is coming forward. We also are discussing in the context of HTA how to look into these more sophisticated applications. So it's certainly a very key area that we need to look into the different developments, and certainly what Germany has done. And I know also that in Finland you have also strong developments in these areas that we are talking about today. So this is just a little bit of reflection on this point. And of course on Darwin, I think Paolo Alcini will be much more able to go into more details, but for me, Darwin is really a very powerful development that we are having here in bringing together the EMA with the agencies from the 27 or the 30 the states of the European Economic Space, where we will intend to collect information or data that will be then able to be transformed into evidence. It's very important that we have these two elements in mind. Data is one thing, evidence is another thing, and we work based on evidence, not only on data. And of course, this is necessary that it will be connected with what will stem from the European health data space. You know, the process is being in the legislative process now to be approved, but this is foreseen, and the collaboration between all parties that are involved with Darwin, including the center that is in the Netherlands supporting that, this is ongoing. So I think there will be, of course, this will make us more capable from the side of the agencies to really have a system that will be capable of responding to needs once we also have this broader approach in Europe with the European health data space, which I think is very important that we make this connection. But certainly Paolo will give you a little bit more detail when he will have his presentation. Thank you very much again.
Thank you. Paolo, do you want to?
Yes.
There's a question from the chat. Yes.
I'm the Zoom keeper here. And the question is, in your view, what is the role of patients in maintaining quality of his or her own medical record, as we increasingly speak more about patient empowerment?
Patients, we have to include to have patients more and more part of our decision-making system. Also, in our own agency, we have a project which we call it Incluir, which in English means to include. So, and of course, we should have not only the patients being heard in different processes that we are taking, but also to see how, of course, we can also let's say, frame in more specifically information that we will gather from the use of the different technologies. So this is something that by having good systems, and I think here in Portugal, I think this is something that is very important, because we have a very strong and integrated systems. Then we can also, in specific areas where they are much more important, particularly when we are also using medicines in a very earlier stage, to also foresee ways of gathering specific feedback from the patients. The importance here is to frame and to develop methodologies that we can use when we are looking into this evidence. But patients are key, and they are already central, but they have to be even more in developing this process where we want to make benefit of the use of health data.
Great. Thank you so much. I really appreciate you making time to join us from Lisbon this morning. And we are going to move on to the next. So from medicines and access to medicines to a bit more of a systemic view. Sofia, can you tell us about the risk-based supervision and data-driven supervision model that the Portuguese Health Regulatory Authority is developing, and the importance that it has for the current landscape? Thank you.
Okay, so good morning to you all. Can you hear me?
Yes.
Okay, good. First of all, I'd like to thank the invitation to be here. It's always great to come back to the medical school. So thank you to Professor Altamiro da Costa Pereira, and thank you to Paolo and all the organizers of this conference. Actually, I must say that I changed my topic completely yesterday. As a keynote, I guess I have a bit more freedom to decide what to talk about. And so I decided to take advantage of it. And so I bring you today a presentation with a twist. Because, of course, regulation is based on data, but we work mainly with data at the provider's level and not really at the patient level, not so much. And at the moment, we have almost like a revolution inside of our organization. And so I thought it would be worth talking to you a little bit about that. It's a bit off the program, I guess, but it's also about data. So I'm going to talk to you about risk-based supervision towards data-driven regulation of the healthcare system. So starting from the beginning, from those who don't know the work that we do at ERS, we are an independent public body, and we regulate the activity of healthcare providers from public and private and social sectors, for profit and not for profit. So this includes everything from huge hospitals to small individual physicians' offices, acupuncture centers, everything you can imagine. Medicines and medical devices are out of our scope, and that's what INFARMED does. So we complement each other, if we can say that. We aim at delivering independent assurance about the compliance with the legal requirements for healthcare services and premises, the protection of healthcare users' rights, including access to healthcare, the legality and transparency in the economic relations between all agents in the healthcare system, so providers, third-party payers and users, what we normally call economic regulation, and assuring fair competition in healthcare markets whenever appropriate. How do we do it? We are responsible for registering and licensing healthcare providers in order for them to enter the market, handling patients' complaints. At the moment, we are getting over 100,000 a year. So this is a huge source of information, and this is where patient health data comes in. Carrying out inspections and audits to healthcare facilities, carrying out investigations of events with impact on patients' rights and/or on the quality and safety of care, and applying the resulting sanctions, producing studies, reports, reviews, advice papers, and recommendations, and assessing the quality of healthcare providers. This would be another whole presentation. We don't really have time for this, but at the moment we are creating a completely new way of assessing the quality of healthcare providers. Problems. We have over 36,000 registered healthcare providers, completely different from each other, and we have 100 staff. So this is a problem everywhere. We never have enough resources. We have the money, but we have a huge regulated universe. So the problem that we're facing is the same that every regulatory agency in the world faces. We have to decide how to prioritize our activity, where to look at and why. And for that, we need data. So we need to make sure that we have a timely, rational, efficient, and effective regulatory intervention. And for that, we need a lot of good quality and reliable data. And so we decided to look outside of Portugal because we don't really have a comparator here. And we've been working very closely with other supervisor agencies in the EU to see how we could change the way we work based on data in order to make sure that we don't have to look at the 36,000 providers at the same time with the same level of attention, because it just doesn't make any sense and it doesn't work. And so going back to theory, we started to look at different ways of approaching supervision. And there are basically three main models that have been applied. Two of them are more traditional. Another one is a bit out there. It's been used in banking supervision, in insurance supervision. It's brand new in healthcare. So starting with the first one, and then I'll show you graphically what it means. We have a compliance-based supervision model. And this means that basically the supervisor focuses on ensuring that all providers comply with laws and regulations. So it's a formal way of supervising activity. Then we have incident-based supervision. What this means is that whenever an incident is detected, either because it's reported or because we observe it, we act on it. So we are reactive to incidents. And basically, normally we look at individual providers for this. So whenever there's a problem, we intervene. We have a mix of these two in ours, and I'll show you afterwards. But the third one that we're trying to implement, and it's really, really, really very complex, is a risk-based model of supervision. And so what you try to do is assess all the time, so continuously, the healthcare system and the individual provider's level of risk, which means merging a lot of different types of information and making sure that we identify the problems on time, and if possible, we prevent them. So this is the point of it. So graphically, so it's easier for you to see it. Starting from the first one, basically what we're saying is, okay, so we add the supervisor, a new provider comes in the market, either public or private, for profit, not for profit, it doesn't matter. We have to make sure before they enter the market as a regulator that they comply with rules and regulations. Otherwise, they can't go in. So there's a first moment of high level attention to that provider, if you want. After we make sure they comply, monitoring levels go back to the minimum. And then we have occasional compliance assessments. They can be random or they can be sectorial or whatever. So sometimes we look at them. We either visit them or we ask for information. And if everything goes well, if there isn't a major problem, monitoring goes back to the minimum again. This would work if we had 20 providers, because we could do it all the time. We could visit them all every year. We could go there, we can talk to them. With 36,000, it's completely impossible. So we actually do this when they enter the market, and we have inspections along the way. But if we only did this and we did it blindly, it could take years and years and years until we visited a given provider again, especially if they're small ones, because we would concentrate on hospitals and big providers, of course. If we look at incident-based supervision, what we have is minimum level of monitoring. We identify an incident. We have a regulatory intervention, so high-level attention. After that, we have a post-intervention monitoring to make sure that everything is okay. And if they comply, it goes back to the minimum again. So as you can see, we have a mixture of these both, because we start with a high-level attention when they come in the market, and then we do this whenever an incident occurs, either a complaint from a patient or something that comes out in the news, whatever. So risk-based supervision is a bit more difficult to do, because first of all, we have to make sure they comply with the rules when they come in the market. So there's a high-level attention to a given provider. And then we have preventive monitoring all the time, and at the higher level than with the other models. So we always look at them all the time. If there's an incident, or better even, if there's increased risk, so we know that something could happen, because we have signs, we have more complaints about something. Nothing major has happened yet, but we can see that something is happening, either because they are in financial trouble, or because there are more complaints, or there are, I don't know, nurses shortages, whatever. We know something is happening there. And so, if possible, we intervene before the problem happens. And so we prevent them. If it's not possible, because incidents will always happen, then we intervene faster. And then there's a regulatory intervention, post-intervention monitoring, and after compliance, it goes back to preventive monitoring. So this allows us to look at the 36,000 and intervene whenever necessary, but knowing why we are looking at them. It seems easy. It's really, really difficult. We've been working on this for 2 years now, and we're still in the beginning. So what does this allow? It reduces the probability of incident occurrence because we have timely preventive interventions and alerts. It increases the probability and readiness of incident detection whenever it happens. It reduces the time of reaction to incidents whenever they do happen. Most of all, it allows us for a more efficient allocation of resources in the regulatory agency because we know where to look at. We can focus our resources. If everything is okay in a given provider, if we have no signs there's a problem, why would we go there? We can go there if we can afford to do it, but it's better to look the other way and look to the ones that really have a riskier level. And this allows for a combination of isolated post-incident interventions, because we still have to do whatever we're doing now, nothing changed, and predictive systemic interventions. So we can look at the provider's level, but we can also look at segments of the sector, because a problem could be in dialysis, not just in that provider. It could be a systematic problem. And so it allows us for different types of intervention. And we've been doing this, and it's interesting because this was my project for years. When I arrived, this is what I really wanted to do. And then when we were starting, COVID came in. And I said, okay, so now we have to do it faster. But it actually forced us to look at the healthcare system in a different way, because we had to change the way we work. We couldn't do anything like we used to do. And this was a huge discussion with all the agencies in Europe, because everybody was saying, okay, we can't do inspections because we could bring COVID inside or we could bring it out. So let's keep inspections to the minimum and make sure whenever we do one, it's because we really have to do it. So about data, because this is what we're talking about, and my freedom has limits. We have a huge amount of data in-house, but really so much data you can't imagine. We collect it, we produce it inside, and we produce it for different purposes, and we get it from multiple sources. What's the problem? We are one of the smallest healthcare supervisors agency in Europe, and we have the largest range of legal attributions. This is a fact. And so it's difficult to organize a small organization to do so much and to make sure that we cover the basics. And so what happens is that we have our different types of interventions organized by departments, like every organization. And this means that data is scattered across different departments. And so the main challenge at the moment is how to structure the information we already have, make sure that we can organize it in individual risk profiles for each provider, for the 36,000, and identify the data that we don't have and decide how to collect it, how to work with other organizations. And we were saying it, and it's essential. We have to work with each other because we all aim at the same thing. So in order for us to get some of this information, we depend on other organizations, providers, but also some public entities and so on. Risk-based supervision is incredibly demanding on data. There's a diversity of sources. We need simple, clear, objective, and easy to collect data. Most of it will come from providers. So if we ask hospitals to shift some of their efforts from patients to collecting data and sending it to us, and they think it's just a bureaucratic thing, they will send poor quality data. They will take their time to send it. They have to, because they are legally obliged. We can ask for whatever we want, and they have to send it to us. But we have to make sure that this isn't too much of a burden for them, because their main purpose is to provide healthcare. And then we have to keep data permanently up to date, because if there's a lag, then data is completely useless for us. We have to have IT systems that are reliable and safe, because we collect mostly we collect data at the provider's level, but that's based on patients' level information. So we have to make sure that data is safe and IT systems are essential for that, especially if we're talking about such a huge amount of data. And so we need also some new analysis methods. At the moment, we are, for example, using artificial intelligence on patients' complaints. So we have to be inventive and find ways of working better and better every day. And also the model, sorry, I'm just looking at time. The model must be able to learn and to improve itself continuously because the healthcare system changes. And so if we don't change the model, it will not represent reality and it's useless. So basically what we're doing in-house at the moment is making sure that each department is a source and the user of information from this model, and that they learn to work together in order to work well. And so we're asking ourselves, what are we doing well? And that's fine. What aren't we doing well enough, and can we do it better? What aren't we doing at all and should be doing? Because this defines what data we need. What are we doing and shouldn't be doing? And what data do we really need in order to improve our activity? And then we're building individual risk profiles for each provider to inform our activity. This is not going to be published. It's just an internal model for us to be better at what we do. So we have them divided in components that are the same for all healthcare providers, from hospitals to acupuncture premises. So it's irrespective of their nature, the size, the services they provide, it's the same. And then we conduct risk assessments for each of these components. And each component, of course, will include a range of indicators, and these indicators can have different weights, of course, because some are more serious than others for assessing risk. Of course, some of these risk indicators in each component may not apply to all providers. For example, some of them only apply to NHS providers, some others only apply to private providers, so they will be blank, basically. And then we divided, and this is the innovative thing. I'll think of writing an article on it, actually, because this is the first model in Europe that does it, because the other supervisors in Europe don't have the same attributions that we have. They mainly do inspections. So they have many sources of information and then one exit to decide where to go for an inspection. We have multiple ways of intervening. So basically we're organizing the risk profiles in terms of what we do. So how good are they in terms of access to healthcare? How good are they in terms of healthcare quality and patient safety? And this includes health data at the patient's level. How good are they in terms of legality and transparency in the economic relations between the different agents in the healthcare system? How good are they, if appropriate, because in the NHS it doesn't apply, for example, in ensuring fair competition? How good are they in respecting and guaranteeing other patients' rights, patient satisfaction, and how good is intervention between a provider and heirs? And then we monitor each of these components and we determine the probability of an incident and the impact it will have if it occurred, and then it informs heirs' regulatory intervention. From these results, this goes to each of the departments, and so we can have different ways of intervening. If nothing happened yet, but we have an increased risk level, then we can have preventing monitoring measures. So we can have information campaigns, we can have training sessions with providers, we can produce studies and reports, or, for example, we can ask for more additional information to understand what's going on. We can conduct on-site inspections, we can produce supervision alerts, because nothing happened yet. We just know that risk is going. If now we'll send out orders, instructions, and recommendations to providers. We can apply fines. We can apply accessory sanctions. If things are really bad, we can close the premises. Basically, we can have a suspension of activity until we make sure that it's safe. And then we can have regulatory measures. So we can produce general recommendations. We can produce and publish regulatory frameworks to make sure that the system works better. So we are working very, very fast. We have a lot of people working on this. We actually have a SEMA project going on. So it's really going very, very fast. But going back to data is a problem at the moment. because some data we simply don't have. Some data we do have, and we don't really know how to use it for this. And I have my team saying, we need everything. We need everything because everything is important. And this is a huge problem because there's 100 of us. Not everybody is working on this because the rest of the activity is still going on. And at the moment we have hundreds of indicators that we want to produce. And so I keep telling them, okay, but what we really need, because researchers keep complaining that they don't have the data. I'm an academic in my real life, so I kept complaining about it. And all of a sudden, I'm the regulator, and I can ask for whatever I want. As long as they have it, they have to send it to us. And this is very, very tempting. So what we have to be aware is that too much data may also become a problem. It can overwhelm providers because all they do is send us information. It can overwhelm our own teams. And it can actually become an obstacle to effective intervention. And so the key is to determine what's the data that we really need, make sure it's real, because we depend on it otherwise, like Professor Altamiro was saying, garbage in, garbage out, so it's pointless. Making sure it's verifiable, because otherwise, again, for us as a regulator, it's useless. It's reliable, it's available on time, because if it takes a long time to collect it, by the time we get it, it's useless, and that we can make sense of it. Because if we have data and we don't really need what's in it, then again, there's no point. So finding the right balance between enough data and not too much data is maybe the biggest challenge of all. And this is my challenge at the moment. I keep telling them maybe a bit less, a bit less. So hopefully, if this works, and I'm about to leave it, so this is my legacy, I hope it works, this will allow us to better contribute to an increasingly more responsive, equitable, safe, high quality and patient-centered healthcare system, because actually this is what we're here for. This is our concern. This is our main goal for all of us. So thank you very much.
Thank you. Thank you so much, Sofia. And for the sake of time, I will keep the discussion going. But let me just tell you, you have a very difficult job.
Yes.
Predictive analytics is hard in every dimension or wherever you look within the healthcare ecosystem. But having to do this on a real-time, real-time data and responding to it on a real time. Yes, you have a very difficult job, and maybe we can have a 2-day summit just to help with that, solving some of those issues. Okay, so we keep on moving, and we want to go back to the European level. So, Paolo, you're with the European Medicines Agency, and its goal is to foster scientific excellence in the evaluation and supervision of medicines for the benefit of public health in the European Union. And clearly, data quality is the backbone of this evaluation and supervision role played by EMA. So Paolo, what are some of the main trends that you are seeing in terms of the data standardization and data quality related to medicines regulation at the European level, and in particularly in the context of medicine regulations, how is the development of international data standards progressing in Europe? And what would you like to see happening in this space in the near future? And at the European level, how do you see it fostering? What elements are you being put in place to foster data quality specifically for medicine regulations? Small questions.
Thank you, Vanessa. Good morning, everybody. First of all, it's an honor to be here, and I'm very happy to be here. Just a few words on me. I'm leading a team for healthcare data, and I have around 20+ year experience in designing, implementing, reviewing both system processes, standards related to data. And I saw that data quality is a global problem in the past, and it's becoming more and more a problem going forward, because as our colleague was mentioning, we are getting more and more data. We are going towards the big data challenge as well. At the moment, we have an opportunity to improve and to do better with the data. Why that? Because the European Medicine Regulatory Network, and that is just to frame my intervention today, is providing a mandate to improve and to further develop and fostering the use of data for scientific assessment and for regulatory decision-making. In fact, we have also pharma strategies that are being developed. We have also the European health data space that was mentioned earlier. And the idea is that data-driven decision-making should be based more and more often on data standards. Therefore, standardization can be open standard, can be more formal standard. Data quality, that is going to be key. Data discoverability as well, because you can have the best data in the world, but if you don't know that it exists, you cannot use it. Data access, meaning we have a link on the GDPR, for example, that we needed to provide the best access possible for research, for regulators, etc., but making sure that patient, in this case, the identity of the patient is not disclosed. And data governance, that is also included in all this discussion. And all these contribute to what we call robust evidence. And also, in order to implement all this, we need to remember that we are in a path together. So all what we do, we always engage with all the stakeholders available, meaning from regulators, from at national level, from other agencies, like, for example, ECDC, the first one that comes to mind at the moment. But also, we are guided by patient. So patient, coming back to one question that was mentioned earlier, are key for our work. We involve them in any kind of aspect in which we are doing. For example, what we have implemented is what we call the Big Data Task Force. The Big Data Task Force was set up a few years ago with the mandate to define and to review what the regulatory network can do with big data. Big data is a very generic term, and there are many definitions. But in our context, big data can be, for example, adverse drug reaction, can be omics data that is coming from patient. And this data is constantly evolving, is constantly changing and arriving on a day-to-day basis. And we need to manage all that properly. The vision for the task force was that the regulatory system should be able to integrate big data in its processes, in its assessment, in this decision-making. And this is to develop innovative medicine, to provide medicine, life-saving treatment to patients faster, and optimize the safe and effective use of the data that are made, that reach the market. So what we have at the moment is from the task force that the task force created a report and for big data, and they have created 10 specific recommendations to unlock the potential of big data in the regulatory setting. From the task force, when they finished their work, we created what we call the Big Data Steering Group, that is made of a group of people that put together, in collaboration with many stakeholders, a work plan for the implementation of those 10 recommendations. And for example, patient and healthcare professionals are represented in the Big Data Steering Group. At the moment, we have the latest version of the plan that is just being released this year and is covering 22 to 25. These are high level, the recommendation and the activity that you are looking at. Today, we are focusing on data quality, for obvious reason, data standardization, because data standardization is key also to foster and monitor data quality. Data discoverability, for what I mentioned before. So we needed to understand what is in the data set, which kind, and for two reasons, also to monitor the data set, the quality of the data set, but also to foster the use of the data. And afterwards, I will briefly mention one use cases for which we do all this, the Darwin EU, that was mentioned previously. Now, data standardization is something extremely important. We have published a report, meaning a strategy for data standardization relatively recently. And let's say that the age of data of digitalization is also the age of data-driven decision-making, and the creation and adoption of data standards supports this activity. And without data standards, the collection, processing, management, all the life cycle of data is going to be much more difficult and on a hoc basis. And everyone will do in a different way. And the integration in the interoperability of data is going to be at risk. The data standardization strategy that I mentioned before, the one that we publish, is something that is not static. It's going to be maintained and developed over time. And until now, let's say the approach taken is to develop and implement a data standard as being ad hoc and very slow. And the creation of the strategy should enable the reduction and the effort for a quicker approach to adopting and implementing standards. Why we are implementing standards and how we are implementing standards in the regulatory setting. The European Medicine Regulatory Network can implement standard when we have a legal obligation, and therefore we are obliged in a sense to implement them. For example, there are two standards that I'm quite proud of because I was involved, and in some aspect I led the development of some part of them related to the ICSR standard and the ISO/DMP. Both these standards will have a lot of impact in for the safety of the patient. The ICSR is the standard on which pharmacovigilance data is collected, so adverse drug reaction all over Europe, for example. When we don't have obligation, but we have some kind of jurisdiction where we can, in a sense, impose some kind of standard, we do that via guidance that we can ask, for example, market authorization holder to adhere to. When we don't have obligation and we don't have also jurisdiction, we can follow the discussion in more broad forum and to participate in decision-making process for data standards. At the moment, the recommendation in the data strategy are focusing on 4 thematic areas, I would say: the medicinal product, healthcare and study data, safety and risk management, and submission of information. So, for example, for the medicinal product, we have the implementation of the ISO/DMP, therefore the creation of a medicinal product dictionary that in principle should be able to identify unequivocally all the medicine that are on the market and are going to be on the market in the various stages of the medicine life cycle. Healthcare and study data, for example, we can engage with ICH to define, to structure clinical trial protocol. And and in this case, for example, we develop HL7 FI resources, for example, or we collaborate with CDISC to review or to adopt some of their standards, for example, for the raw data underpinning clinical trial. Healthcare study, consider the possibility of expanding the work of clinical trial protocol and study reports on organizational data and developing a common data model that is going to be used also for the EHDS and Darwin EU. Safety and risk management. Then we have submission. So, for example, EAF, the electronic application form for new medicine. As next step, we are going to develop an implementation strategy, a roadmap for implementing all the recommendations that are defined in the strategy itself. Now, moving to data quality. So data quality is a global issue, as I mentioned. And what we are going to do at the moment in the European regulatory network is to define a data quality framework. We have done a landscape analysis in the past month in order to identify what can be relevant for the regulatory network. And we have identified many other data quality frameworks, the CAN, for example, just to mention one. So the objective of this data quality framework is to improve consistency, to enable the development of standardization approach or a standardized approach for data quality, facilitate a more systematic use of data, support the trust on the stakeholder, because if you have a specific data quality framework implemented, the stakeholder has more trust on the outcome of the decision taken. And the first draft to the framework will provide general consideration, because the first step is to talk the same language, to understand the same concept, and will outline how to measure data quality in different scenarios, and intended to serve as an overarching framework. And the most important thing is that the European regulatory network didn't define this in a silo, but we have collaborated with other stakeholders. And for example, we have collaborated with the Towards European Health Data Space Joint Action, the TEDAS, and with other stakeholders. Now, the purpose of the data quality frameworks is to provide assistance that can apply for a wide range of data sources to support regulatory decision making. We define terminology, we describe a range of metrics and dimensions, and we define that data maturity model that is going to be extremely important to understand where an organization, where a process is fitting. The data quality is assessed always not as standalone, not as in theory, but is assessed from the point of view of fitness for purpose. So you need to have a use case, you need to have a purpose for which you collect the data or for which you use data. And here we enter in the scenario of primary use of the data against secondary use of the data. And in this particular setting, we are saying that the document, the framework that we are defining is as the goal to support regulatory decision making. We have 5 dimensions that have been described to define data quality, and some of them are very standard, so I will not, let's say, spend much time on that. So we have reliability, coherence, extensiveness, relevance, timeliness. But there are also other concepts. So data is not just a matter of metrics, it's a matter of processes, it's a matter of tools, it's a matter of systems that are working together, integration. So the first aspect that we put together is we need to define determinants, so areas in which we want to look at data quality. So for example, we define foundational determinant, intrinsic determinant, question-specific determinant. For example, the foundational one are pertain to the processes and system through which data are generated, collected, and made available. Foundational determinants are what affects the quality of the data, but it's not part of the data themselves, in a sense. And therefore they don't depend on and cannot be derived from the content of the data set. Intrinsic determinants instead are different, pertain to aspects that they are inherent to a specific data set, are what can be derived given a data set and possibly some external generic knowledge, but without know-how of the context in which the data was generated. So are business case agnostic in a sense. And after there are question-specific determinants pertain to aspects of data quality that cannot be generally defined independently of a specific question. And that is coming to the use of the data. Another element that is extremely important is that data quality is not just a process that you need to do at the end, a posteriori, in order to fix issues, but it needed to be done all over the various types of the data life cycle. So we have, for example, data quality aspect that need to define when data requirements are defined, when data collection process are defined, when the processing of the data is taking in place. So for example, you are ETLing the data to create a data warehouse. You need to have some concept in mind there. Testing, procurement, publishing the data, consumption of the data. And after just to conclude on this part is related to the maturity models. So for all the determinant, foundational, intrinsic, and specific, we have maturity models. So for example, taking the foundational, the first step is to have a system, a process that is documented, meaning is we know what we are doing in a sense. Then we go to formalized, when we document in a way that is following industry standard, and then is implemented. So the system and all the process are implemented in the system itself. And then we are going to a more visionary things that is all of this is automated. Now, this standard is for public consultation until tomorrow. So if you want to have a look, please feel free and provide our comment. Even if you send a few days later, it's not a big deal, but have a look to it if you are interested. And one aspect is that the next step, it will be to define use cases for specific data quality and use cases. So for example, the next step, it will be to look at real world evidence quality consideration. Why that is important? It's important because real world data, Darwin, that I'm talking in a second, are going to be in the spotlight in the next month and year. Metadata is important, as I mentioned, for identifying data sources that are usable and useful for replying to research questions, epidemiological analysis. This is why we have published a metadata list and why we are producing a good practice guide that set out processes for the use of that. My last slide, penultimate slide. Darwin EU. Darwin EU is a good use cases that in which all this kind of a topic that I discussed are coming into place. Darwin is a federated network of data and expertise and service that generate reliable evidence from real-world healthcare data, from secondary use most of the time. And the idea is to have Darwin EU delivering over 150 studies annually by 2025. What will Darwin do? Will provide scientific expertise, will maintain and expand the federated network of data partners, will conduct scientific study and analysis, will deliver training and governance, and will also enable, coming back to the question from our colleague, enable the European Medicine Regulatory Network and the EMEA and the scientific committee of the EMEA to make use of the European health data space in the context of medicine regulation. It will act more as a pathfinder in the EHDS pathfinder. And the last point, who's going to benefit from it? Everybody, every stakeholder. It will be you, patient, and the health professional, because we will have a faster access to innovative medicine and safe and effective use. European Commission, key use case for a European health data space. National competent authority, support health policy and delivery healthcare system. HTA bodies and payers to support better quality decision, including cost effectiveness. EU International Health Agency, like ECDC, as mentioned before. Academia, increase the use of real world evidence. Industry, enable better evidence, supporting decision-making, for example. And here I conclude. Key messages. Medicine regulation will become more and more data-driven, and therefore we need to evolve. Data will be standardized, discoverable, and of known quality representatives, allowing choice of optimal data sources. That is the key. Delivering through collaboration for all the stakeholders. We always have event, public consultation, in which we ask stakeholders to collaborate or to connect. For example, on the 1st December, we have the third big data forum, stakeholder forum. And also it's patient focus. In everything we do, we involve patient. Thanks a lot. Sorry for maybe overrunning a bit.
Thank you, Paolo. And maybe if you want to join us here back at the table, I will break my own timekeeping rules. And if there's 1 or 2 questions from the audience, we will note them down before we do our own wrap up here at the table. Nope. Everybody's starting to need some coffee. So let me, I think we have achieved the purpose and the goal that we wanted for this session, which was to give everyone enough food for thought and frame the discussions for the next 2 days. What I would like to hear as we wrap up the session, maybe the same question for both Paolo and Sofia. So from your perspective and the organizations that you're in now, what would you like to see happening in the next year or so to improve the quality of healthcare data and increase access to quality care for all? And Sofia, maybe I'll put a twist for you as well, because I find the model that you are describing fascinating. So if you were, what would you need to have this model matching your own vision for it full speed in the next year or so? What would you need for that to happen?
This is a very difficult question. Well, we depend on the quality of data at the source. And one of the main problems we're facing, even for the indicators that we know we need, that they are stabilized, and we have to monitor them irrespective of the model. There's a huge problem in terms of the ability that providers have to give us the data. So, for example, for all the Portuguese that are present, one of the things that the Portuguese Healthcare Regulation Authority has to do, it's one of our legal obligations, is to make sure that providers respect maximum waiting times that are determined by law. And in order for us to do it, we have to know the track of each patient. So we have to know when surgery became needed, for example, and when did it happen? When was the first consultation needed and when did it happen? And providers in many cases cannot give it to us because they don't have it. It's not just because they don't want to give it to us, because if they do, we can sanction them because they're not, they're going out of the legal waiting times, but they just don't have the information. And so we have a lot of data, but at the same time, in many areas, and this is crucial, especially after COVID, because there's a backlog of surgeries and everything else to do because they have to stop it. And for us to monitor it and make sure that they do it, we need to get the information, and they just don't have it, and it doesn't depend on them. And this is the bureaucracy coming in and the centralization coming in. It has to exist, but it doesn't depend on each provider because, for example, IT systems are central. So if that's not collected, then providers simply cannot give it to us. So for this model to work, we have a lot of information that doesn't really depend on providers because we can produce them in-house. The rest is a big problem because waiting times are a huge problem in the Portuguese healthcare system. They are a huge problem everywhere, but here at the moment, it's a huge problem. And for providers to manage their own data, they have to have it. So even for their own management and organization, they need this. Then we need it at the macro level to intervene if they don't respect waiting times, but they themselves cannot monitor their own work. And in primary care, it's even worse. So hopefully, and we produced recommendations to the Ministry of Health and so on, because some things have to be decided centrally. So hopefully, the production and collection of data inside the providers will get better, so they can use it better in order to work better, and then we can use it as well. So in a purely ERS vision, our main concern is this, because we really need data on time and complete, because otherwise if we get information on waiting times for one provider and we don't get it for another one, then we'll be sanctioning and fining one of them and not the other, and it doesn't make any sense, because if we want to be equitable, we have to have information across the board. So, well, fingers crossed.
Good. Well, I think that's a good magic wand type of wish to have, and hopefully it gets sorted because we would all benefit from it. Paolo, for you as well, the same question. So what would you like to see happening in the next year or so within the European context to advance the use of healthcare data quality?
So Vanessa, I think that meaning we have a work plan implemented as I was defined, as I was mentioning before. So data standardization, data quality, metadata are key aspects on which we are going to work. And what I would like really to happen is that all the stakeholders, all the experts in Europe that have interest are collaborating with us in order to provide feedback on public consultation that we do, on when we define new processes, when we have event there, in order to not be only the European regulatory network imposing something, and maybe making mistake as well, because if we don't listen, we can make mistake as anyone else. And why data quality is so important? Because there is something that is coming up always more prominent in different setting, artificial intelligence. So if the data that we feed to artificial intelligence algorithm is not perfect from data quality, we will have bias, we will have issues. Therefore, the data even more need to be perfect, because before maybe we had perfect or almost perfect, of course, but before we have some safety net. In those algorithms is much less, because sometimes algorithms are black box. So
you're absolutely right. Thank you. So for sake of everybody's ability to get a coffee before the first session, I am wrapping this up. And so I think it's important as we go through the conversations, we keep in mind some of the key messages that were said here. To me, it was very striking, the need for timely data, the need for data that is fit for purpose, and data that is responding to the patients and the system's needs, so that we can all make the best decisions that we can for the benefit of us all. And so with this, let me thank you, Sofia. Let me thank you, Paolo. Paul, thank you so much for setting this up. I think we got to a very good start for the Health Data Forum, and I hope the rest of the next 2 days will be of such high quality as this one. Thank you, everyone.
Thank you, everyone. We'll skip the announcements for the next opening plenary. You have tickets for coffee and water or refreshments in the reception if they are not in your bags already. We'll do announcements for the plenary in the next plenary here. Please go to your rooms for the breakouts after the coffee break and enjoy your time together here in presence.
Absolutamente, não tinha ideia.